MTAD and tetracycline. Now, for answering such questions, you should know that what is MTAD and tetracycline. MTAD and tetracycline, they are antibiotic-based irrigants, root canal irrigants. Okay, MTAD is also known by the name of BioPure. It is also known by the name of BioPure. So both are antibiotic-based irrigants. And which antibiotic they contain? They contain the same antibiotic, that is tetracycline hyclate. Okay, so what is the difference the question is asking you? Is it the detergent which is different? The concentration of antibiotic that is different? BioPure. Or the type of antibiotic that is different? Concentration of antibiotic and the detergent that is different. Okay, the type of antibiotic, we know that both of them contain tetracycline hyclate. So C would be ruled out, is not the correct option. Okay, type of antibiotic is same. The question is asking about the difference. Simply, if you know the composition, MTAD consists of 150 milligrams per 5 ml of tetracycline hyclate. Tetracycline hyclate as the detergent. Tetracycline, on the other hand, consists of just 50 milligrams per 5 ml of the same tetracycline hyclate as the antibiotic. So the concentration of antibiotic is different with them. What is the detergent? With the MTAD, someone has asked me to repeat the question number 1. I would do that. Okay. Let me first finish off with the question number 2 that I am currently discussing. So the question is asking what is the difference between MTAD and tetracycline. MTAD and tetracycline both are antibiotic-based irrigants. MTAD is also commercially available under the trade name of BioPure. BioPure. The concentration of same antibiotic, that is tetracycline hyclate, is 150 milligram per 5 ml for MTAD, and it is 50 milligrams per 5 ml of same antibiotic for tetracycline. If we talk about the detergent, then in MTAD, the detergent is Tween 8D, which is a polysorbate detergent. Okay. And in tetracycline, if the detergent we talk about is a polypropylene glycol. Polypropylene glycol as the detergent. So what is the difference? Difference is in the detergent as well as the concentration of antibiotic. So the answer would be option D. The difference between MTAD and tetracycline is both in the concentration of antibiotic and the type of detergent, but not in the type of antibiotic, because the antibiotic remains the same. Apart from these two things, that is the antibiotic and the detergent, MTAD also consists of citric acid. With citric acid is present in MTAD, that makes it pH acidic, and 2.15 is the pH of MTAD. What is the pH of MTAD? Because of the presence of citric acid, it is 2.15 acidic in pH. So these are the two antibiotic-based irrigants. And if you remember what has been taught to you in the class, that these two antibiotic irrigants, as a usage protocol, that are always used as a 5-minute final rinse of the root canal. See, there are various irrigants available. Some are used initially, like sodium hypochlorite, to remove the necrotic pulpal tissue from the root canal. Some irrigants like chlorhexidine, MTAD, tetracycline, they are always used as a final rinse, because we have to utilize the property of the substantivity and smear layer removal from the root canal. So both MTAD and tetracycline, they are used as a 5-minute final rinse of the root canal. Okay. On a student's request, I am switching back to question number 1. Question number 1 is asking, isolite is a modern method for what? Isolite is basically a term acronym consisting of two things, isolation and illumination. Light means illumination. So as can be seen on the screens, this is a handpiece like device which is used for tooth isolation and illumination. As can be seen in the picture over here, it is how the isolite is being used. The isolite is connected with the handpiece and it illuminates the oral cavity for better visibility, as well as it is causing simultaneous isolation of the operating field. So isolite is a modern method for tooth isolation. What is a conventional method for tooth isolation? Rubber dam isolation, one of the frequently used methods. Okay. Coming over to question number 3. The following device is used for what? There's a picture of a device shown on your screens. What is this device? It is used for cold testing of the pulp, to supply nitrous oxide for conscious sedation. The device is used for kinetic cavity preparation, or it is used for tooth desiccation to locate the cracks. What is this device? See, this device is basically called odonto test. Odonto test. Okay. There is a cylinder of solid carbon dioxide which is passed through a plexiglass tube or a plastic tube, and what we get, this is a carbon dioxide stick for cold testing of the tooth. Okay, this is a carbon dioxide stick for cold testing of the tooth. So what is this device? Please do not get confused with nitrous oxide, etc. Although it is a cylinder, here it comes as a distinction that there is a plexiglass tube or a plastic tube into which a carbon dioxide stick is produced. So when we pass this solid carbon dioxide through this tube, it forms a carbon dioxide stick that is used for cold testing of the pulp. This carbon dioxide has a temperature of negative 78 degrees Celsius. It is one of the coldest agents available for testing of the tooth by cold application. Pulp sensibility test. Okay, and this odonto test is a device for making the carbon dioxide stick. So answer to this would be option A, that is cold testing of the pulp by way of solid carbon dioxide. You have to also remember that solid carbon dioxide is the method of choice for pulp testing for teeth with full coverage crowns. Okay, in the options, even if laser Doppler flowmetry is there, but the question is asking that what would be the method of choice for pulp testing in a tooth with full coverage crowns. The full coverage crown can be a full metal crown, a porcelain fused to metal crown, or it can be a full ceramic crown. Any type of full coverage crown, the method of choice for pulp testing in that tooth would be solid carbon dioxide, because it is the coldest agent, and when we apply such coldest agent to the full coverage crown, the cold is able to go through the crown to the pulp and we can know the status of the pulp. Okay, so this is the method of choice for teeth with full coverage crowns. Also, cold testing is one of the most accurate pulp sensibility test. 3 pulp sensibility tests are there: hot test, cold test, and electric pulp tester. The most accurate of the sensibility test is cold test, that is carbon dioxide stick test. Moving over to question number 4. Again, this is a picture based question. You have to identify the device that is shown. Now this can be a little confusing, but you can see there is a handpiece like thing with a file like projection into the pulp chamber only. And the pulp chamber in the root canals, they are flooded with irrigant. So something held into a handpiece of file-like device is inserted into the pulp chamber only, that is filled with irrigant. What is this? Is it light walker, gentle wave, Instalight, or endo activator? See, endo activator is basically a sonically activated device. And it goes into the root canals. Here, the device is placed only into the pulp chamber and it is not inserted into the root canal. So option D is ruled out. Now we are left with options A, B, and C. Instalight. Instalight is a system for disinfection of the root canals by ultraviolet light of 254 nanometers. Again, no light is being shown over here. So option C is ruled out. Now we are left with light walker and gentle wave. Both of these are irrigation methods. Gentle wave uses multisonic method. Multisonic irrigation method. And light walker uses erbium YAG laser. Okay. Now you can see there's a tip that is placed into the pulp chamber and it generates energy into the irrigant. So this device is a light walker device. Option A would be the answer to this question. Okay, light walker is the brand name. And which laser is used? Erbium YAG laser is used with a wavelength of 2940 nanometer. These wavelengths are important, which are also given to you in your class notes. This technique or this device that is called light walker, which uses it uses laser energy for the activation of fluid inside the root canals. And it works on the principle that is called PIPS, that is photoacoustic photon induced streaming. Photon induced photoacoustic streaming. The principle is called PIPS, that uses laser irradiation for activation or agitation of liquid inside the root canal. And the technique is PIPS, and the brand name of the device is light walker. Light means laser light, walker means it enhances the agitation of liquid inside the root canal. Option A would be the answer to this question. Okay. Question number 5. Not usually a cause for the post-treatment disease. Not usually a cause. Persistent intraradicular microorganisms, extraradicular infection, foreign body reaction, or periapical pocket cyst. Okay, which is usually not a cause for post-treatment disease. Post-treatment disease means after doing root canal, if there is secondary infection and development of periapical pathology, what can be the possible reasons for that? Then persistent intraradicular microorganisms can definitely cause post-treatment disease, isn't it? Extraradicular infection means this is the root of the tooth. Instead of infection going from the root canal to the periapical tissues, there's entry of infection from outside the root canal, that is called extraradicular infection. And if you remember the endodontic microbiology taught to you, the extraradicular infection is caused by two important groups of microorganisms. One is Actinomyces species, another is Propionibacterium propionica. Okay, so extraradicular infection can definitely cause post-treatment disease. Foreign body reaction. What is foreign body reaction? Suppose during root canal obturation, the irrigants and the medicaments, they go outside the domain of the root canal. Your obturating materials like your cilia and your gattaparcha cone, they go outside the confines of the root canal, they would induce a foreign body reaction. So they can also cause post-treatment disease. Periapical pocket cyst. What is a pocket cyst? Cyst can be of two types. One cyst is continuous with the root canal. This is called pocket cyst. One cyst is isolated from the root canal, that is called true cyst. So periapical pocket cyst that is continuous with the root canal, once we successfully treat the root canal, sterilize the root canal, it heals and is usually not the cause for post-treatment disease. But on the other hand, if it is a true cyst is a cyst, a periapical cyst that is isolated completely from the root canal. It is not continuous with the root canal. Even if when we are treating the root canal by making it sterile by chemical and mechanical means and obturating it, since the cyst is isolated, it would not heal and may give rise to post-treatment disease. So true cyst gives rise to post-treatment disease, but the pocket cyst does not give rise to post-treatment disease. So the answer to this would be option D. Usually not the cause for post-treatment disease. Okay. Question number 6 is again a pictorial question. The following cross-section depicts which generation of the rotary instrument? Okay, all of you must be remembering that there are 5 generations of nickel titanium instruments. Okay, this picture depicts which generation? As a revision, if we talk about the first generation, they are the passive instruments with radial lens. So these instruments would be having cross-section like U-shape in cross-section. Okay, definitely this instrument is not having a cross-section like this. The second generation instruments, they are active instruments, okay, without radial lens. What is a radial land? The radial land is this flattened area of the burr or the instrument blade that prevents the gouging or engaging of the instrument inside the root canal. Okay. These instruments would have a cross section like this or like this, distinctly different from the first generation. The third generation instruments, okay, they have special heat treatment. The fourth generation, they have alternate motions. Alternate motion can be either reciprocation or up and down. If we have to remember the examples of up and down, it would be a self-adjusting file. SAF stands for self-adjusting file. Reciprocation, wave 1, and reciproc. What are these? These are examples of the respective generations. If I talk about example of first generation, 3 examples you can remember: profile, GT file, and light speed. Okay. Second generation example you can remember, that is pro taper. Okay. Race, hero. These are examples of your second generation, prominent examples. And then finally, the fifth generation instruments, they have off-centric design. Off-centric design means the axis of rotation. The axis of rotation does not coincide with the center of the instrument. As you can see over here, this is the axis of rotation, and somewhere here would be a center of the instrument. So it is a eccentric or off-centric design. fifth generation instrument. So this example is in option C would be the answer. The instrument shown in this picture is example of fifth generation nickel titanium instrument. Prominent example of fifth generation would be Pro Taper next. Okay, this question has been asked couple of times with this picture only, and these are the 5 generations that you should remember with the prominent examples. Okay. Question number 7. An avulsed tooth that is replanted back in the socket after long extraoral time, the choice of intracanal medicament is. There has been a case of tooth avulsion, a form of trauma, and it has been out after long extraoral time. What would be the choice of intracanal medicament? Ledamix paste, triple antibiotic paste, calcium hydroxide paste, or CHX stands for chlorhexidine. Now to answer this question, you should remember that this is the marker word over here, long extraoral time. Whenever the tooth has been avulsed and out of the oral cavity for extra periods, when we replant it back, there is always a chance of inflammatory tooth resorption. So to prevent the inflammatory tooth resorption, some intracanal medicament is given that can prevent the tooth resorption. Out of the options given over here, the ledamix paste is the one that prevents tooth resorption. Okay. Other three, triple antibiotic, calcium hydroxide, and chlorhexidine, they do not prevent tooth resorption. So whenever the tooth has been out of the oral cavity for extra duration, there are chances of inflammatory root resorption. To prevent that, we put an intracanal medicament like ledamix paste that prevents tooth resorption. So answer to this question would be option A. If the question is simply mentioning a tooth with avulsion replanted in a early manner, then it would be calcium hydroxide, that is the routine medicament used. But long extraoral time, you have to give something that prevents tooth resorption. Answer would be ledamix paste. So let's talk something about the ledamix paste. Please do not get confused. Ledamix paste was introduced by Schroeder. It is a water-soluble non-setting paste. It is a water-soluble non-setting paste, which consists of two things: 3% demiclocycline, which is the antibiotic component, and 1% triamcinolone acetonide. That is the synthetic steroid which acts like anti-inflammatory. So it is a combination of steroid with antibiotic called ledamix paste, a water-soluble non-setting paste. Its mechanism of action: it inhibits bacterial ribosomal protein synthesis. Okay, the principal mechanism of action: it inhibits the bacterial protein synthesis. That's why it is bactericidal, antimicrobial. Okay, and it also prevents tooth resorption. These are the two important properties that you have to remember for ledamix paste, a water-soluble non-setting paste with these two components, antibiotic and an anti-inflammatory steroid. So answer would be option A. I hope there is no confusion. Please do not get confused with triple antibiotic paste. Triple antibiotic paste is basically used in cases of regenerative endodontic treatment, teeth with immature open apex. Okay? Immature non-vital teeth. Coming over to question number 8. True about hybrid GIC is. Now, to answer this, you should know what is hybrid GIC. Hybrid GIC is a term used for basically combination of resin modified glass ionomer cement, GIC and resins, RMGIC. So what is true about RMGIC? Less water sorption. It is more biocompatible, higher fluoride release than GIC, and higher bond strength. What is true? Less water sorption is incorrect because of the presence of resin component. Okay, it consists of hydrophilic resin, that is hydroxyethyl methacrylate. In the hybrid GIC, again, if you remember the class notes when we talked about the dental cements, we have discussed resin modified glass ionomer cement, which consists of a hydrophilic resin, that is hydroxyethyl methacrylate. Since this resin is hydrophilic, it absorbs water and it causes up to 8% by volume of expansion. Okay, up to 8% by volume expansion. So first option is wrong. It causes more water sorption. Is it more biocompatible? No. Again, because of the resin component, the resin monomers, we make them more allergen, more toxic, so it is less biocompatible than conventional GIC. Higher fluoride release than GIC. Again, this is untrue because the amount of fluoride released from RMGIC is less than conventional GIC. If we talk about fluoride release, it is slightly less or equal to conventional GIC. CGIC means conventional non-modified GIC. So definitely it is not higher. It can be either equal or lesser. So option C is wrong. Higher bond strength, this is the correct. So option D would be the answer because of the presence of both acid etching reaction and polymerization reaction. The bond strength of resin modified glass ionomer to the tooth structure is higher as compared to conventional non-modified GIC. That is something you have to remember. So option D is the correct answer over here. This is true about hybrid GIC. So please do not get confused with the term hybrid GIC. It indicates resin modified glass ionomer cement. Coming over to question number 9. The profile instruments are used at speed range of. Now it is asking about profile instrument. If you just look at the generations of nickel titanium instruments that we have discussed above, the first generation instruments, I have given you 3 examples: the profile, the GT files, and the light speed. All of them are passive cutting instruments with radial lengths. It is asking the speed range of this. Now, to answer such questions, there's an array of endodontic instruments available in the market these days, and it is not possible to remember the speed range of all of them. But it is highly unlikely that they would be asking you about one particular group and not the other. Just to confuse you, the name profile has been given. Do not get confused with it. Majority of the nickel titanium rotary instruments, they operate in the speed range of 150 to 300 RPM. So answer to this question would be option B, 150 to 300 RPM. This is the speed range for majority of the rotary nickel titanium instruments. If we talk about exception, is group 1 instrument only, as the name indicates, light speed. It is used at much higher speed of 2000 to 2500 RPM. Okay, so you can remember, if the question is asking you about light speed, it would be this. Otherwise, majority of the nickel titanium instruments, it is 150 to 300 RPM. Moving over to the next question. That is question number 10 as displayed onto your screens. The time taken by smooth surface incipient lesions to become cavitated is. This is something you have to remember. The question is talking about smooth surface lesions. Smooth surface incipient lesions to become cavitated is 18 plus minus 6 months. Option C would be the answer over here. This is something you have to remember. Related to this only, there are certain questions which have come, that is how much time taken for caries to develop in xerostomia. The caries develops in as little as 3 weeks. Okay. Okay. Similarly, after radiation, it takes about 3 months for the caries to develop. Some related figures I have given you. And it takes 18 plus minus 6 months, nearly 2 years for incipient lesions to become cavitated. 18 plus minus 6 months. Question number 11. The splinting of avulsed tooth using arch bar is. It is a rigid fixation and correct method of splinting. Semi-rigid fixation and correct method of splinting. Rigid fixation and incorrect method of splinting. Semi-rigid fixation and incorrect method of splinting. So it is basically asking you about avulsion and its related splinting method. So as a blanket statement, you can remember that for all sorts of dental trauma, the fixation or the splinting of the teeth is always non-rigid. This is the recommended method. This non-rigid fixation of the teeth or splinting of teeth is also called physiological splinting. Physiological splinting of the teeth. Okay. Now when arch bar is used, arch bar is made up of stainless steel and it is used for fracture stabilization with intermaxillary fixation. From your oral surgery lessons, you must have come across arch bars. So whenever we are using arch bars, it is a rigid method of fixation. Arch bars are not non-rigid or physiological, they are rigid. So we rule out the options B and D, that is semi-rigid. Now, rigid fixation and correct method of splinting is wrong, because as I have told you, we have to always go for a non-rigid or physiological splinting of teeth, whatever may be the cause of trauma, whatever may be the type of trauma, because rigid fixation has the potential of causing tooth ankylosis, which do not allow the tooth movement to occur. The teeth are likely to become ankylosed. So rigid fixation and incorrect method of splinting is the correct answer over here, option C. Okay. Some of you have answered it correctly. I'm happy to see that. Okay. That you know what is the method for splinting of teeth. And if we talk about, this is about the method. If we talk about the duration, just as an extension, for avulsed teeth, the duration is 7 to 10 days or 1 to 2 weeks. The duration of splinting for tooth avulsion is this. If the question is asking you about tooth avulsion with simultaneous dento-alveolar fracture, okay, there's fracture of the bone also, then it would be 6 to 8 weeks with dento-alveolar fracture. So these are the two durations that you have to keep in mind, 7 to 10 days and 6 to 8 weeks. Okay. Coming over to question number 12. The best option for incisors shown in IOP, this is best treatment option for the incisors shown in this IUP is. Now, what is peculiar about these? You can see these are the outlines of the teeth. These are the pulp canals. This is the outline of the tooth. This is its pulp canal. So these are basically teeth with immature apex. Teeth with immature apex. So what would be the best treatment? Revascularization or regenerative endodontic procedures? MT apexification, calcium hydroxide apexification, or apexogenesis. Okay. A, B, and C. All three are treatment options for such teeth, for teeth with immature pulpless status. But the best is revascularization, which is a biologically based procedure. It helps in regeneration of the lost tissues. It not only increases the root length, it also increases the thickness of the root. It causes apical closure and it causes resolution of the periapical lesion. So all desirable efforts are attached whenever we undergo regenerative endodontic procedures for teeth with immature pulpless status. So best treatment option would be REPs. Option A would be the answer. The second best is MT apexification. The third best is calcium hydroxide apexification. So the sequence of treatment would be first, second, and third. In that sequence, you have to answer. The best would be option A. 12th, it is A. Question number 13. The pH of pulp in the state of diseases. This is a straightforward question. Acidic, alkaline, neutral, or basic. pH of pulp in the state of disease. Diseased state of the pulp is called pulpitis. Pulpitis means inflammation of the pulp. And whenever there is inflammation, the pH decreases or it becomes acidic. So in the state of disease, the pH of the pulp would be definitely acidic. Option A would be the answer. Okay. Coming over to question number 14. What is the magnification used in endodontic loops? 2 to 8x, 8 to 16, 25 to 45, 50 to 75x. This is a relatively very simple question. Endodontic loops, they provide low magnification in the range of 2 to 4 up to 8x. Okay, so definitely option A would be the answer. For higher magnifications, we use dental operating microscope, DOM. This also has got three ranges of magnification: the low, the medium, and the high range of magnification with dental operating microscope. Okay, the low is in the range of 4 to 8x. The medium is in the range of 8 to 16x, and 16 to 26 or up to 30x is high magnification of dental operating microscope, three ranges of magnification. The question is asking you about loops, which is always low. Usually the range of magnification for loops is 2 to 4x. Some modern loops which work on prismatic geometry also provide up to 8 times the magnification. So option A would be the answer. There have been questions related to magnification of microscope. It is divided into three: low, medium, and high, and majority of the procedures of clinical importance, they are done under medium magnification of the microscope. Majority of the procedures like endodontic surgery we have to do, the medium magnification would be used. High magnification is only used to study fine anatomic details. Fine anatomic details. Okay, fine anatomic details like presence of vertical root fractures or other cracks we have to identify in the teeth, or presence of isthmus, etc. These anatomic details, they are done only under high magnification. Otherwise, majority of the procedures are done under medium magnification of the microscope. Coming over to the question number 15. EDTA has all of the following function except which is not the function of EDTA, ethylene diamine tetraacetic acid. Chelation, definitely it is used for chelation of calcium ions. Pulp fixation. Does it do pulp fixation? No. Pulp fixation is done by mummifying agents like formocresol and not EDTA. Smear layer removal? Yes, EDTA removes the smear layer. Antimicrobial? Yes, EDTA is also antimicrobial because it inhibits bacterial enzymes. So, which is not the function? Pulp fixation, option B would be the answer. EDTA is also antimicrobial, but not a very potent antimicrobial. The principal function is chelation of calcium ions. It causes up to 50 microns depth of chelation. It chelates calcium ions up to 50 microns, able to debride and remove the calcium ions up to a depth of 50 microns. And the duration of action of EDTA is nearly 15 minutes. The pH is 7.2 to 7.3. Some of the facts related to EDTA. And smear layer removal, the time of smear layer removal is 1 minute on a standard. So these are the different set of questions that can be asked for EDTA. The duration of action, the time required for the removal of smear layer with EDTA, what is the pH, and what is the depth of demineralization. Coming over to question number 16. The reading 0 on electronic apex locator indicates what? Okay. Minor apical foramen, major apical foramen, CDJ, or radiographic apex. We know that electronic apex locator is used for working line determination, and it works on the principle that electrical resistance between two tissues, that is oral mucosa and periodontal ligament, is always a constant, that is 6.5 kilo ohms. So PDL means, if we talk about the tooth, okay, in the apical anatomy, this is the apical constriction and this is the apical foramen. So this is a minor diameter and this is the major diameter. So whenever the file would touch the PDL at the major apical foramen, it would give the reading of 6.5 kilo ohms. So reading 0 indicates major apical foramen or apical foramen, major diameter. Option B would be the answer. Okay. Please do not get confused. It is an important question which has been asked a couple of times. For understanding this, you should know what is the principle of electronic apex locator. It measures the resistance between PDL. Periodontal ligament is present where? It is present at the apical foramen and not the apical constriction. Okay. So major apical foramen reading 0. So we have to subtract 0.5 to 1 millimeter as a safety factor from the electronic working length measurement, isn't it? Electronic apex locator is getting apex at where? It is getting the apex at the apical foramen or the major diameter and not the apical constriction. And which is the ideal point? The ideal point is CDJ or somewhere near the apical constriction. So whatever length you get from electronic apex locator, you have to subtract 0.5 to 1 millimeter as a safety factor. Okay, so apex, the question may ask you the reading apex or the reading 0. Do not get confused. Both of them mean the same thing. In an EAL, it indicates major apical foramen. Okay, option B would be the answer. Coming over to question number 17. The mixing time of GIC must not exceed 30 seconds, 15 seconds, 20 or 40 seconds. This is a relatively straightforward question. You should remember that the mixing time of GIC is usually in the range of 30 to 45 seconds. Okay. This is the mixing time for GIC standard. And if we look at the options, option D is the best possible answer. It should not exceed 40 seconds. Less than a minute, ideally in 45 seconds, it is completed. Should be less than a minute. A straightforward question. Question number 18. The proximal box for class 2 amalgam restoration is prepared where? Equally in enamel and dentine, 2/3 in dentine, 1/3 in enamel, 2/3 in enamel and 1/3 in dentine, depends on the KDs. It is asking you about a class 2 preparation for dental amalgam. A class 2 preparation classical would be having a shape like this. Okay. Is it that? So this is the proximal box. This proximal box is usually prepared with a number 245 burr, which is the standard burr used. We know that number 245 burr is something like this, the shape of truncated cone. The head length is 3 millimeters. The head diameter is 0.8 millimeter. So we make a proximal ditch cut. This 0.8 millimeters consists of 0.3 millimeters in dentine and 0.5 millimeters in enamel. So 2/3 at the expense of enamel and 1/3 at the expense of dentine. Answer to this would be option C. It's good to see that all of you are knowing this. 2/3 at the expense of enamel and 1/3 in the expense of dentine. In other words, figuratively, we are talking about it is usually about 0.8 millimeter wide, the proximal box, 0.8 millimeter wide. It is 0.5 millimeter inside the enamel, 2/3 in enamel, and 0.3 millimeter inside the dentine or 1/3 in the dentine at the expense of dentine. Coming over to the question number 19, that is the last question for today's session. What international caries detection and assessment score is given for the lesion shown over here? What is the ICDAS score for the lesion shown here? Now, you should remember that it is a pictorial score of 0 to 6 from the healthy tooth structure to the grossly cavitated tooth structure. From healthy to grossly cavitated tooth structure, the score of 0 to 6. And here you can see there is discoloration of the tooth structure without surface breakdown. Isn't it? There is gross discoloration, undermining of the lesion is there. but surface breakdown is not there. So it would be option 4. Sorry, option C, that is score of 4. Okay. Score of 0 to 6 is given. If it is cavitated with enamel and slight dentine, it would be score 5. If it would be grossly cavitated with lot of dentine, it would be the score of 6. So it is a visual classification system based upon the scores of 0 through 6. Okay, so option C or 4 would be the answer to this. These days we get a lot of questions based upon the pictures, or majority of them are based upon some devices, etc. I think majority of the things have been given to you. And this was the last question for today's session. Right? With this, I am winding up, and I am sincerely hopeful that I have been able to do justice with the subject and you guys are well prepared for examinations. All the very best, have confidence, and please trust your class notes of whatever teacher they have given you, whatever subject. They have done very hard to make you excel, and we are equally bothered and happy for you that you have been able to make up this. So my best wishes with you all. Please do well. Okay. Thank you very much for being connected. With this, I am signing off.